HighBridge, a division of Recorded Books, presents Black Health in the South. Edited by Stephen S. Coughlin, Lovoria B. Williams, and Tabia Henry Akintobi. Read by Emana Rachelle. Publisher's Note: this audiobook contains references to visuals present in the print and ebook editions of the book. Preface: this volume was written by outstanding contributors who are nationally and internationally recognized for their work. It provides important information about the health and well-being of African Americans in the southern United States. The audience for the book includes graduate students, health professionals, members of health advocacy organizations, and researchers from many different disciplines, including epidemiology, behavioral science, medicine, nursing, sociology, health disparities, policy studies, and African American studies. This book will likely also be of interest to members of nonprofit organizations, government agencies, and health advocacy organizations. Practitioners at local, state, and federal agencies and departments will also find it relevant. The book is organized in 4 parts. The first part, Foundations, provides an overview of the health of African Americans in the southern United States and information about several foundational topics: the social determinants of health and disease, race, racism, and health disparities, poverty, income, and health equity, and access to quality, culturally appropriate health care. The second part of the book, Methods, discusses research approaches that are important for addressing health disparities among African Americans in the South. These include health intervention studies, faith-based interventions, and clinical community-based research networks. The third part, Health Disparities, discusses disparities in cardiovascular disease, diabetes, kidney disease, and end-stage renal disease, interpersonal violence, mental health, major forms of cancer, maternal health, and infant mortality. The last part of the book, Future Directions, examines approaches to ameliorating and eliminating health disparities among African Americans in the southern United States. Our hope is that this unique volume will provide a pivotal discussion of the prevalence of, determinants of, and potential solutions to health disparities that affect African Americans in the South and elsewhere in the United States. We anticipate that it will stimulate efforts to prevent and control these disparities for the benefit of at-risk communities and future generations of African Americans. 1. Foundations. 1. Overview. Stephen S. Coughlin, Ph.D., M.Ph. Lovoria B. Williams, Ph.D., FNP, BC, FAAN, and Tabia Henry Akintobi, Ph.D., M.Ph. The southern United States is a geographic and cultural region of the United States located between the western United States and the Atlantic Ocean. It is south of the Midwestern United States and northeastern United States, and north of the Gulf of Mexico and Mexico. The region is known for its culture and history. As defined by the U.S. Census, the region includes 16 states: Delaware, Florida, Georgia, Maryland, North Carolina, South Carolina, Virginia, West Virginia, Alabama, Kentucky, Mississippi, Tennessee, Arkansas, Louisiana, Oklahoma, and Texas. However, Delaware, Maryland, and the District of Columbia remained with the Union during the Civil War. As of 2020, an estimated 114,555,744 people, or 37% of all U.S. residents, lived in the South, the nation's most populous region. The historical and cultural development of the South have been influenced by the institution of slave labor on plantations in the Deep South, the legacy of racism magnified by the Civil War and Reconstruction, the segregated system of separate schools and public facilities known as Jim Crow laws that remained in effect until the 1960s, and the presence of a large portion of African Americans in the population. After the Civil War, the South's population, infrastructure, and economy were devastated. Thousands of people were on the move as African Americans strove to reunite with families separated by slave sales. Other freed people moved from plantation areas to cities or towns. African Americans in the South were made free citizens and were given the right to vote with the passage of the 13th, 14th, and 15th Amendments to the Constitution of the United States. Secret vigilante organizations such as the Ku Klux Klan arose quickly after the war's end that used lynching, physical attacks, house burnings, and intimidation to keep African Americans from exercising their political rights. Jim Crow laws were passed to segregate public facilities and services, including transportation. In the late 19th and early 20th centuries, thousands of African Americans left the South for cities in the Northeast and Midwest in the movement known as the Great Migration. In their pursuit of justice and voting rights, African Americans participated in large-scale activism during the civil rights movement of the 1950s and 1960s. Most of the major events in the movement occurred in the South. Historically, the South relied heavily on agriculture and was highly rural after 1945. It has since become more industrialized and urban. The expansion of cotton cultivation after 1800 required more slave labor, and the institution became an integral part of the South's economy. In the early 20th century, invasion of the boll weevil devastated cotton crops in the South, prompting more African Americans to leave the South for northern and western cities. World War II was a time of dramatic change in the poor, heavily rural South as the federal government developed new industries and military bases. Farming shifted from cotton and tobacco to include cattle, rice, soybeans, corn, and other foods. Industrial growth increased in the 1960s and greatly accelerated in the 1980s and 1990s. Several large urban areas in Texas, Georgia, and Florida grew to over 4 million people. In the late 20th century, the South's service economy, manufacturing base, high technology industries, and financial sector experienced a boom. However, the 10 poorest big cities in the United States include Memphis, Tennessee, and Miami, Florida. In 2011, 9 of the 10 poorest states were in the South. The South has lower percentages of high school graduates, lower household incomes, and a lower cost of living than the rest of the United States. African American descendants of the slaves who were brought into the South compose the second largest racial minority in the United States. According to the 2000 federal census, they account for 12.1% of the total population. The majority of the African American population remains concentrated in the South. This group has contributed heavily to elements, Christianity and the Bible Belt, foodways, art, and music of Southern culture today. Health disparities among African Americans. Compared to other racial groups, African Americans have a higher risk of adverse health outcomes and premature mortality. Life expectancy in the United States in 2015 was 75.7 years for African Americans, compared to 87.7 years for Asian Pacific Islanders and 79.2 years for whites. The disparity in life expectancy, which is particularly pronounced for African American men, is driven by marked racial disparities in leading causes of death, such as heart disease, diabetes, and homicide. African Americans also experience pronounced disparities in cancer mortality. African Americans have poorer cardiovascular health and higher cardiovascular disease, CVD, mortality than non-Hispanic whites. The higher burden of CVD among African Americans is a primary cause of disparities in life expectancy between African Americans and whites. The higher prevalence of CVD risk factors, example, hypertension, diabetes mellitus, and obesity, underlies the relatively earlier age of onset of CVDs among African Americans. Hypertension is highly prevalent among African Americans and contributes to disparities in stroke, heart failure, and peripheral artery disease. The prevalence of diagnosed and undiagnosed hypertension among African American men, 42.4%, and women, 44%, greater than or equal to 20 years of age, is among the highest in the world. The excess in stroke mortality for African Americans is substantially larger in southern states than in non-southern states. The stroke belt is a region of the southeastern United States that has 50% higher stroke mortality rates. African Americans living in southern states are at higher risk of death from stroke than are whites. At age 55 years, the risk of dying from stroke is about 3 times greater for African Americans than whites. The reasons for the stroke belt are unknown, but may include regional differences in stroke risk factors, such as hypertension, obesity, and diabetes. African American men develop diabetes mellitus 1.52 times more often than white men, and African American women are 2.14 times more likely to develop diabetes than white women. The combined prevalence of diagnosed and undiagnosed type 2 diabetes mellitus is 21.8% in African Americans and 11.3% in non-Hispanic whites. African Americans are twice as likely to die from diabetes than non-Hispanic whites. In a study of racial disparities in diabetes mortality in the 50 most populous U.S. cities, African Americans had statistically significantly higher mortality rates than whites in 39 of the 41 cities included in analysis. The prevalence of diagnosed diabetes is higher in southern states than in non-southern states. Obesity rates are higher among African Americans than whites. Among adults greater than or equal to 20 years of age, African American women had the highest rates of obesity at 58%, followed by African American men, 38%, white men, 34%, and white women, 33%. 9 southern states, Mississippi, Louisiana, West Virginia, Alabama, Oklahoma, Arkansas, South Carolina, Kentucky, and Texas, have obesity rates that are among the highest in the nation. Rates for hypertension and diabetes for these states are also the highest in the nation. The southern United States also has the largest number of people who die from stroke. Although reduced obesity, a healthy diet, increased physical activity, and the use of healthcare services can improve population health and health equity, these factors are influenced by social determinants such as income, employment, and education. Neighborhood socioeconomic status, SES, is inversely related to diabetes and hypertension. African Americans are 4 times more likely than whites to live in the lowest SES neighborhoods. Poverty rates are 2 times higher among African Americans, 25.4%, than among non-Hispanic whites, 10.4%. Unemployment rates are more than 2 times higher among African Americans than among non-Hispanic whites. There are also substantial disparities in educational attainment. Fewer African Americans graduate from high school, 72.5%, than non-Hispanic whites, 87.2%. The health disparities that are seen among African Americans, particularly those who live in southern states, are not limited to cardiovascular disease, diabetes, and obesity. African Americans who live in the South also have increased risk of sexually transmitted diseases, HIV/AIDS, infant mortality, and mental health conditions. The HIV epidemic is most pronounced in the South, which has the highest rates of HIV infection. In the United States, approximately 46% of people living with HIV reside in the South. African Americans are disproportionately affected. The HIV diagnosis rate among African Americans is 8 times that of whites. In 2016, African Americans accounted for 54% of all new HIV diagnoses in the South. African American women account for 69% of all HIV diagnoses among women in the South. African American men who have sex with other men account for 59% of all HIV diagnoses among African Americans in the South. The causes of health disparities. African Americans who live in the southern United States have a unique history that includes hundreds of years of slavery, injustices experienced during the Jim Crow era, the Great Migration, the Civil Rights Movement, and contemporary experiences that include reverse migration from cities in the Midwest and Northeast to the South. the Black Lives Matter movement, and continued efforts to address inequities and structural problems that affect the lives and health of African Americans. The legacy of slavery and the limitations on civil rights until the middle of the 20th century have had an important effect on the social, economic, cultural, and political experiences of African Americans in this region. These factors have resulted in significant racial and socioeconomic health disparities. The work of Michael Marmot and others has highlighted the importance of social gradients in the relative deprivation that is a driving force in health disparities. Socioeconomic factors such as unemployment, lack of education, poverty, and income inequality are among the most important social determinants of health. Economists use the Gini coefficient to measure income inequality. From 1990 to 2018, the Gini coefficient in the United States rose from 0.43 to 0.49, reflecting a nationwide increase in income inequality. Income disparities frequently coexist with other socio-political determinants of health, which include access to health insurance, rates of employment, quality of education, support for public assistance programs, and access to quality health care. Unequal access to these social resources for marginalized racial/ethnic groups, particularly African Americans, leads to increased hospitalization, illness, and death across many chronic diseases. In 2018, all 17 states in the South were among the top 20 with respect to highest income inequality. It is well established that low-income people are at increased risk of an array of adverse health outcomes and are more likely to die prematurely. Numerous studies have documented a socioeconomic gradient. People on each step of the socioeconomic ladder exhibit improved health outcomes over the people on the rung below. Compared to whites, African Americans receive less income at the same education levels and have markedly less wealth at equivalent income levels. These disparities in income are reflected in racial differences in life expectancy. A 1998 study found that for each mile of 12-mile metro route from downtown Washington, D.C. to Montgomery County, Maryland, the life expectancy of the resident population increased by approximately a year and a half. Social determinants of health play an important role in creating sustaining health disparities among African Americans. Frameworks of social determinants build on the social gradient concept. The idea is that individuals with lower social status have greater health risk and lower life expectancy than those with higher status, and that the impact of social position can accumulate over time. Social determinants of poor health include inadequate food and nutrition, lack of education, unemployment, inadequate housing, and lack of access to affordable quality health care, social support, and social connections, social networks. The social context in which people live and work influences their health. For example, social connections between neighbors and greater social cohesion and social capital have been found to be protective against depression. Conversely, exposure to interpersonal violence has been associated with increased depression, depressive symptoms, and post-traumatic stress disorder. Racial discrimination, food insecurity, poor family relationships, and a history of abuse and neglect have also been associated with negative mental health outcomes. In contrast, living with family, satisfaction with family relationships, and family connectedness have been associated with fewer depressive symptoms. The World Health Organization defines the social determinants of health as the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. Adverse childhood experiences, including exposure to domestic violence, parental incarceration, and parental mental illness, are strongly associated with adverse health consequences later in life. The Institute of Medicine notes that the social environment may influence health behavior by shaping norms, enforcing patterns of social control, providing or not providing environmental opportunities to engage in particular behaviors, reducing or producing stress, and placing constraints on individual choice. The environmental context of living in an area of low or underemployment, high crime, residential crowding, and poor living conditions contributes to a state of chronic psychosocial stress. Accordingly, Behavioral and metabolic risk factors are increased disproportionately among those with high psychosocial chronic stress, leading to a strain on the coping abilities of individuals. Chronic stress due to a disadvantaged social environment may independently affect health outcomes negatively. One hypothesized mechanism for the relationship between chronic stress and poor health outcomes lies within the hypothalamus pituitary adrenal (HPA) pathway. Increased hypothalamic pituitary adrenal dysfunction has been associated with lower socioeconomic status, higher cortisol variability, and increased measurements of central adiposity. Chronic stress due to a disadvantaged social environment may independently impact health outcomes negatively. Some consider racism to be a social determinant of health for people of color. Structural racism refers to the way societies foster racial discrimination through mutually reinforcing and unequal systems of housing, education, employment, earnings, credit, healthcare, and criminal justice. These patterns and practices reinforce discriminatory beliefs, values, and distribution of resources. Structural racism is reflected in the residential segregation of African Americans, which is associated with adverse birth outcomes, decreased longevity, increased risk of chronic disease, and increased rates of homicide. As Williams etc. all note, racial residential segregation refers to the occupancy of different neighborhood environments by race that was developed in the U.S. to ensure that whites resided in separate communities from blacks. Segregation was created by federal policies as well as explicit governmental support of private policies, such as discriminatory zoning, mortgage discrimination, redlining, and restrictive covenants. The pathways through which structural racism and residential segregation harm health include exposure to dilapidated housing, the substandard quality of the social and built environments, limited opportunities for high-quality education and desirable employment, and restricted access to quality health care. Residential segregation systemically shapes access to, use of, and quality of health care at the individual, neighborhood, provider, and healthcare system levels. In addition to substandard housing and residents in high-crime areas, examples of structural or systemic problems that adversely affect health include poverty, lack of insurance, inadequate access to health care, lack of education, health illiteracy, lack of transportation, and food insecurity. For example, as a result of redlining and other historical contemporary injustices, African Americans are less likely to own a home or to have built-up home equity, which places them at risk of financial distress if they experience an illness such as a heart attack, stroke, or cancer. Although redlining is no longer legal, discrimination in the rental and housing markets against communities of color is still pervasive. Another example of a structural problem that contributes to health disparities is the war on drugs and the tough-on-crime policies enacted in the 1970s and 1980s that stereotyped African Americans as drug addicts and disproportionately targeted them for incarceration. Racism harms health through multiple pathways. It exposes people to adverse physical, social, and economic systems and can lead to maladaptive coping behaviors. These exposures can accumulate over the life course and across generations. Interpersonal racism has been shown to have adverse effects on psychological well-being, mental health, and the consumption of alcohol, cigarettes, and illicit drugs. Phelan and Link argue that the combination of our expanded capacity to control death and disease and the presence of social and economic inequalities creates health disparities by race and SES. When we develop the ability to control disease and death, the benefits of this newfound ability are distributed according to resources of knowledge, power, prestige, and beneficial social connections. Those who are advantaged with respect to such resources benefit more from new health-enhancing capabilities and consequently experience lower mortality rates. Disparities are the result. This explanation for health disparities is a core component of the theory of fundamental social causes. The determinants of health disparities are complex and multifactorial. They include biologic and behavioral individual factors, barriers to providers and healthcare systems that include differences in income, education, and health insurance coverage. Racial disparities may be due to differences in biology, increased comorbid conditions, suboptimal patient-physician interactions, and structural problems such as lack of transportation and decreased access to quality care. The use of community coalitions is a valuable approach for addressing health disparities in African American communities. Improving the cultural competence of healthcare providers and the healthcare system are examples of evidence-based approaches to reducing health disparities. A life course perspective, which recognizes the influence of historical changes on human behavior, is useful for understanding health disparities. This perspective recognizes the linkage between early life experiences and later experiences in adulthood. For example, behavioral risk factors, example, cigarette smoking and alcohol consumption, over the life course may contribute more to adverse birth outcomes than current behavioral risk factors during pregnancy. The early programming model of health disparities posits that exposures in early life could influence future risk of adverse health outcomes, such as adverse birth outcomes and adult-onset chronic diseases. Early life socioeconomic disadvantage has been associated with risk of adolescent and adult diseases independent of adolescent or adult SES. The cumulative pathways model conceptualizes declining health as cumulative wear and tear to the body's allostatic systems. Allostatic load reflects physiological changes across different biological regulatory systems in response to chronic social and environmental stress. The life course perspective also emphasizes the ways that humans are interdependent and gives special attention to the family as the primary arena for experiencing and interpreting the wider social world. This perspective sees humans as capable of making choices and constructing their own life journeys within systems of opportunities and constraints. Despite the importance of social determinants of health, genetic and epigenetic factors also contribute to adverse health outcomes and health disparities among African Americans. For example, adverse birth outcomes, which are rooted in institutionalized social disadvantage and structural racism, are mediated through complex interactions with genetic predisposition and expression. Asthma prevalence and mortality in the United States are higher for African American children and adults than for white counterparts. Socioeconomic factors, racial discrimination, differential access to medical care, differential access to housing, patterns of medical care use, and biologic factors such as genetic variation and vulnerability to effects of exposures may contribute to these disparities. Recent advances in exposomics are also contributing to our understanding of health disparities. The exposome consists of all of the exposures an individual incurs over a lifetime, as an embryo, as a fetus, as a newborn, in early childhood, in pre-adolescence, in adolescence, in young adulthood, in middle age, in older adulthood, and in old age, and how those exposures are related to human health. The exposome is dynamic and evolves throughout the lifetime of an individual. It includes internal and external environmental exposures to things such as microorganisms, alcohol, and tobacco, and social, economic, and psychological exposures to factors such as social capital, education, and mental stress. The exposome concept takes into account the full spectrum of possible exposures: diet, dietary supplements, food additives, pesticide residues, microbial organisms and infections, geophysical exposures, environmental pollution, smoking, alcohol consumption, exercise, infections, vaccinations, occupational exposures, consumer products, therapeutic drugs, severe stress, etc. The timing of exposures, and acute and chronic responses to exposures. In contrast to the genome, the exposome is highly variable and dynamic and evolves throughout the lifetime of an individual. Diet is an important example of a culturally influenced environmental determinant of health that likely contributes to health disparities in the southern United States. Traditional African American food, colloquially called soul food, includes a variety of leafy greens, corn, starchy vegetables, grains, fried meats, whole milk, and buttermilk. Many of these ingredients contain high levels of fat, cholesterol, and sodium. Soul